I'm Jason Rizzo. I'm a dermatologist and Mohs surgeon who practices in Southwest Florida at the Woodruff Institute. I'm going to talk to you today about a recent poster we published with Castle Biosciences at the American Academy of Dermatology meeting this year in Orlando, Florida. This poster was the result of a collaboration with the National Cancer Institute using data from the SEER database. That's the Surveillance, Epidemiology, and End Results database, where we can harvest data on the demographics and clinical and histopathological characteristics of tumors and their outcomes. And the goal of the study was to validate the performance of the DecisionDx Melanoma GEP test. For those of you who don't know, DecisionDx-Melanoma is a prognostic test based on gene expression profiling. That's the GEP. It's a test that's performed on biopsy tissue. No additional tissue is needed. It's an add-on test, and it provides additional risk stratification for our patients that adds additional information beyond the standard staging we use with the AJCC. So this study was a collaboration with the NCI, who reached out to Castle and noticed there was a lot of patients in the SEER database who had Castle tests and wanted to know if we were interested in seeing how the test performed using real-world data. These patients were tested prospectively, and this is the largest study of the DecisionDx to date. It has previously been published, the similar analysis with 3-year data and around 4,800 I'm sorry, 4,687 patients doing the similar analysis. But the poster we presented at the AAD this year was an expanded analysis for 5-year outcome data and more than double the number of patients. And the two goals of the study were to validate that the GEP test is able to predict and stratify the risk of melanoma-specific survival in a real-world prospectively tested population. And the second goal was to see if having the test made a difference on survival outcomes. So if you look through the data on the poster, the answer is yes. And that was the answer in the 3-year analysis. So what we see when we look at all stages of melanoma, 9,474 patients, the GEP test score is able to stratify and predict the risk of melanoma-specific survival. And it could do so completely agnostic to other standard staging criteria. So it is a significant and independent predictor of melanoma-specific mortality. If you do a multivariate analysis, the higher risk GEP scores, which are they are scored as low risk class 1A, intermediate risk class 1B/2A, or high risk class 2B. Both of the one intermediate and high risk scores are the most significant and predictive variables, independent variables in a multivariate analysis to predict melanoma specific mortality. Other variables that came out were exactly what you would expect, the variables that we use in standard clinical and pathological staging: Breslow thickness, ulceration status, and then things like age and mitotic rate were borderline or weakly significant. And of course, lymph node status was also another significant predictor, which should be no surprise to us. So that's the first part of the analysis. The test is able to validate and show how robust it is in a real world prospectively tested cohort of almost 10,000 patients. But the second part of the test is really interesting, which is where the question is, did it make a difference? And what they did was they did a matching analysis. They looked for patients in the SEER database who were tested with a Castle test and compared that to those matched in every other clinical, pathological, and socioeconomic variable without a Castle test. So the idea is that the only difference between these two populations were the presence or absence of a Castle test. And the question was there a survival difference? And the answer was, just like in the 3-year analysis, yes, there was a significant difference in survival, almost a 17%, excuse me, there was a 17% reduced mortality rate in those patients who had a Castle test. So the thought here is that having that Castle test, knowing their personalized individual risk based on the genetic profile of their tumor, was able to guide management decisions to escalate the surveillance and management of these patients and allow for a better outcome. And that really is what personalized medicine is. We want to treat individuals and not just the average, and we want to make sure it's making a significant, meaningful difference. So as a dermatologist who diagnoses and treats melanoma, I think this is super exciting. And as someone with a background in molecular genetics, I'm equally thrilled to see us being able to leverage molecular data into the way we care for our patients.